Asthma is a disease in which there is chronic airway inflammation with airway hyperresponsiveness to some triggering stimulus which causes episodic airway obstruction. So what we are saying is, say this is the normal airway and this is the wall of the airway and this is the lumen. Okay, now in asthma, there is chronic inflammation of the airway wall. So there is inflamed wall, and this inflammation also leads to structural changes within the wall with time because of the remodeling which occurs. Then apart from this airway inflammation, there is airway hyperresponsiveness to triggering stimuli. That means certain triggers, for example, some allergen, pollen, dust, it will cause bronchoconstriction in response to these triggers. So there is inflamed wall plus episodic bronchoconstriction to these triggers. In fact, airway hyperresponsiveness is the hallmark of bronchial asthma. Okay. Now, this airway hyperresponsiveness can occur either due to direct smooth muscle hyperresponsiveness. So, wall has the smooth muscle, right? So, it can occur due to the direct smooth muscle contraction to that. Indirect due to the release of the mediators. And there are certain structural changes also going on. That means this is the epithelium, this is the lumen, right? So, below the epithelium, there is deposition of the collagen, that is subepithelial collagen deposition. There is presence of edema and mucosal inflammation. All these lead to bronchial hyperresponsiveness. So it is not only the bronchoconstriction. Because of the inflammation and the structural changes which are occurring due to the inflammation, that is also leading to the hyperresponsiveness. Now, to understand what are the treatment strategies, we should first understand the pathophysiological aspect. So, in these patients, when an antigen presenting cell binds with an allergen and presents it to the T helper cell, this T helper cell differentiates into Th2 type of T helper cell. Now, this Th2 cells releases certain interleukins which include interleukin 4, interleukin 5 and interleukin 13. Interleukin 4 causes B cells to mature into plasma cells and release immunoglobulin E. So this interleukin 4 is responsible for the command to the B cells to release immunoglobulin E. Now this immunoglobulin E binds to allergen on one end. Okay, any antibody has two ends, that is the antigen binding end and the Fc end, that is the complement binding end. Now this antigen binding region binds to the antigen and the other region binds to the receptors present on the mast cell. So here we have the Fc receptors on which this IgE binds. And when this happens, interaction of the immunoglobulin E with the mast cell, it leads to mast cell degranulation. That means the contents of the granules of the mast cells will be released, and these include histamine, leukotrienes like leukotriene C4, D4 and E4. Now, because of this various chemicals which are released, it will lead to airway inflammation. It is responsible for vasodilation, increase in the capillary permeability, and it is also responsible for increased mucus secretion, and because of increased capillary permeability, there will be leakage leading to mucosal edema. Then also there is airway smooth muscle contraction. So these leukotrienes, histamine also are responsible for smooth muscle contraction. Then because of the presence of the irritants in the lumen of the airway, there is activation of the cholinergic reflex as well. That means the vagal nerve fibers are activated, and this in turn activates the efferents which supply the smooth muscle, causing smooth muscle contraction. So there is some cholinergic activation as well. Then we have some other interleukins released by Th2 cells, that is interleukin 5, which is responsible for recruitment of the eosinophil and also for the survival of the eosinophil. Then we have interleukin 13, which is also responsible for bronchial hyperresponsiveness. So if we understand this basic pathophysiology, now it will be easy for us to understand the various treatment strategies. So what are these various treatment strategies? First, we have to counsel the patient to avoid the allergen. If the allergen is identified, we have to counsel the patient avoid as much as possible. But obviously the person can avoid, but it is not always possible. So we have other treatment strategies. Second strategy is prevent antigen antibody reaction. So prevent the binding of immunoglobulin E with the antigen, that is second. Third are mast cells stabilizers. That means even if the immunoglobulin E binds to the mast cells, these mast cell stabilizers will prevent the degranulation of the mast cells, thus preventing the release of these chemical mediators. Fourth, prevent the formation of this leukotrienes. Actually, more than the histamine, leukotrienes have been found to have a role in bronchial asthma. So, the drugs which prevent the formation of the leukotrienes. See, this formation of the leukotrienes we saw in our video on NSAIDs. Actually, from the membrane, when phospholipase A2 acts on the membrane lipids, it causes a release of arachidonic acid. And when this arachidonic acid, there is an enzyme, lipooxygenase. When this enzyme acts on arachidonic acid, it leads to the formation of this leukotrienes. So, if we block the action of this lipooxygenase enzyme, that can help in the decreasing the formation of leukotrienes. And if these leukotrienes are formed, the next is prevent the action of this leukotriene. So there are leukotriene receptor antagonists. So they will bind to the receptor so that these leukotrienes are not able to act. So these two drugs which prevent the formation of the leukotrienes or prevent the action of the leukotrienes, they are known as leukotriene modifiers. Then we have the bronchodilators, and as the name suggests, they will dilate the bronchioles and the bronchus and also prevent the further constriction of the bronchus. Then we have the drugs which decrease the inflammation, that is the corticosteroids. So we have seen in the pathophysiology that there is airway inflammation and there is hyperresponsiveness. So we should have some drugs which decrease the inflammation. Otherwise, if inflammation continues, there will be structural changes and they will increase the bronchial hyperresponsiveness. So in that case, these bronchodilators alone will not be effective. Then we have newer drugs basically which block the action of this interleukin 5 and interleukin 13, and we have seen that interleukin 5 is causing eosinophil recruitment, and eosinophils also cause release of this leukotriene. So interleukin 5 antagonists are there, basically the antibodies which bind with interleukin 5, and we have interleukin 13 antagonists as well. So we will talk about these drugs one by one. So first we will talk about the bronchodilators. Now before going into the bronchodilators, let us little bit see the mechanism of how bronchus dilation and bronchioles dilation take place. Actually, on the walls of these bronchi, we have receptors for adrenergic and parasympathetic system. That is for sympathetic and parasympathetic system. So we have beta 2 adrenergic receptors and we have muscarinic receptors, that is M3 type. Now, whenever there is sympathetic stimulation, there is a release of the norepinephrine which is going to bind on this beta 2 receptor. This is going to activate the receptors, and these receptors are G protein coupled receptor GS type. GS means they are going to stimulate the enzyme adenyl cyclase, and this adenyl cyclase will convert ATP to CAMP. When there is increase in the CAMP, this leads to smooth muscle relaxation. Actually, at the level of the myosin, it's something it is doing phosphorylation, dephosphorylation, that we are not going into details. But when there is increase in CAMP, there is a smooth muscle relaxation, and this leads to broncho relaxation. On the other hand, when there is parasympathetic stimulation, there is a stimulation of M3 receptors by the acetylcholine which is released. These M3 receptors also are G protein coupled receptors, but these are GQ type. That is, they are going to activate the enzyme phospholipase C. This ultimately leads to increase in the calcium level, and this leads to bronchoconstriction. Now, KDT writes that these M3 receptors are GI type, but Goodman-Gilman writes that these M3 receptors on the bronchus are of phospholipase C activation type, that is GQ type. Okay, so that's why I have mentioned it as GQ type. So this is the basic mechanism where sympathetic stimulation by stimulation of the beta 2 receptors leads to bronchorelaxation, while parasympathetic stimulation leads to bronchoconstriction. Now, one thing you note here that these M3 receptors for the parasympathetic, they are present on larger airways, right? And beta 2 receptors, they are present on smaller airways. So when we are giving these drugs, they are acting on different airways, and that is why we see that we can utilize these two drugs in combination so that they can have synergistic effect when needed. Okay, synergistic effect can be there. So we will use these drugs in certain conditions in combination to have that synergistic effect. Now, what are the different types of bronchodilators which are used in bronchial asthma? We have beta 2 agonists. We have seen anything which stimulates beta 2 receptors, it is going to lead to bronchodilation. Then we have anticholinergics, because if we block this M3 receptor, see, we have seen parasympathetic stimulation causes bronchoconstriction. So if we block this effect, there will be bronchodilation. And the next drugs are methylxanthines. So let us talk about these drugs one by one. First is bronchodilators, that is the beta 2 agonist. These drugs relieve bronchoconstriction and also prevent bronchoconstriction. So they are having both effects. Actually, mainly they relieve bronchoconstriction, prevent bronchoconstriction as well, because they also prevent release of mediators from mast cells. So there are beta receptors on mast cells, and by acting on them, they prevent the release of these mediators. However, that effect is not that much effective, and when it is used for long term, that effect also goes away. So mainly they are for relieving the bronchoconstriction. So we have short acting beta 2 agonist and long acting beta 2 agonist. Short acting beta 2 agonist, we have salbutamol, or also known as albuterol. Then we have terbutaline. Their action starts within 5 minutes. Very important. Their action starts within 5 minutes and it lasts for 2 to 4 hours. Now, because they are so fast acting, their action starts in 5 minutes. They are the bronchodilators of choice for treatment of acute asthma. So whenever there is episode of asthma, these beta 2 agonists are the treatment of choice. Then we have longer acting, for whom the duration of action is 12 hours, and that includes salmeterol and formoterol. So their action lasts for half a day, that is 12 hours. Among salmeterol and formoterol, S for salmeterol, S for slower onset. Salmeterol is having slower onset, while formoterol is faster acting. And remember that these drugs, long acting drugs, are always combined with inhaled corticosteroids. So for these, the short acting, you will see the inhalers are there, which are having only these short acting beta 2 agonists. On the other hand, the long-acting ones, they are always used in combination with inhaled corticosteroids. Understanding, they are never used alone, always in combination with inhaled corticosteroids, because it was seen that when they were used alone, it increased the bronchial hyperresponsiveness and increased mortality. So they are always used in combination with inhaled corticosteroids. Then we also have ultra long-acting one. For these, the duration of action is 24 hours. So salmeterol, formoterol, when in combination with inhaled corticosteroids, they are taken generally twice a day, because their duration of is 12 hours. Ultra long acting, they can be taken OD, but again, like these long acting, they have to be used in combination with inhaled corticosteroids. So we have indacaterol, olodaterol and vilanterol in this ultra long acting drugs. Now, I told you that short acting ones, these are the bronchodilators of choice for treatment of acute asthma. And always remember that inhaler is preferred over oral, because when we use an inhaler, first of all, the action of this drug is much faster. If you take a tablet, it will take some time for action. Secondly, oral drugs have more frequent side effects. Then what are the side effects of these drugs? Side effects occur because of the stimulation of extrapulmonary beta receptors. So, beta receptors are also present in heart, they are also present in skeletal muscles. So, when these are stimulated, we get the side effects. So, the side effects include palpitation, hypertension, anxiety, when the heart beta receptors are stimulated, then tremors because of the stimulation of skeletal muscle beta receptor. Hypokalemia also occurs because potassium goes back inside the cell. Now, one thing very important to remember here, that even though I am telling that these bronchodilators, that is beta 2 agonists, are the drug of choice for acute severe asthma or acute episode of asthma, but if anybody is having these episodes quite frequently, say suppose twice a day or every week even once, so he has to use the drug daily, in that case it becomes harmful, because frequent use leads to down regulation of the receptors. So that means the number of the receptors decreases. Down regulation means the number of the receptors decreases, and now these drugs will not be able to act any further, and this will in turn lead to more severe attack. So in case the frequency of use of these drugs increases, say more than 2 times per week, if it increases to more than 2 times per week, then we should add inhaled corticosteroids. So again, we will talk about all this, that which drug to use when we talk about the stepping up strategy for the treatment of asthma, right? So that was about the beta 2 agonist. Remember here that these drugs, the short acting beta 2 agonist, that is also known as SABA, they should be used only as required, but if they are used very frequently, then we have to add inhaled corticosteroids. Then longer acting drugs, also known as LABA, that is long acting beta 2 agonist, they should always be combined with inhaled corticosteroids. Fine. Moving on to the next drugs, that is the anticholinergics. So these anticholinergics again are of two types, short acting and long acting. This is SAMA and LAMA, that was SABA and LABA. This is short acting muscarinic antagonist and long acting muscarinic antagonist. So short acting muscarinic antagonists include ipratropium bromide, which acts for 4 to 6 hours, and long acting muscarinic antagonists include tiotropium bromide, which lasts for 24 hours. And even though these are the bronchodilators, but remember, they are not preferred alone in asthma, because in asthma, these smaller bronchioles are affected more. In fact, these are the bronchodilators of choice for COPD, not for asthma. Okay, we will see in a step-up strategy that if the asthma is uncontrolled on inhaled corticosteroid and LABA together, then we may add these drugs, but these are not the first drug of choice for asthma. So they are the bronchodilators of choice for COPD. Why? Well, in COPD, the pathophysiology which I talked in the beginning, it is the cholinergic reflex which occurs. See, most of the bronchoconstriction of COPD is irreversible, but there is some reversible component which can be treated by these drugs, because that reversible component is because of the cholinergic reflex. So because of cholinergic activation, there is bronchoconstriction that can be reversed by adding muscarinic antagonists. Okay. Second, these drugs can be used in asthmatic bronchitis. So there is a COPD component plus asthma component. When both are present together, then these drugs can be added. Then they are combined with beta 2 agonists to terminate severe asthma exacerbation. Again, we will see later when we talk about a step-up strategy and also in status asthmaticus. And that refractory asthma, which I told you, that if the patient is not responding to inhaled corticosteroid plus the LABA long-acting beta 2 agonist, then we add these anticholinergics as well. And remember that where these are acting, they are acting on the larger airways where these M3 receptors are present. So when these two drugs are combined, we get a synergistic effect, because now the action is both on the larger airways as well as the smaller airways. But the onset of these drugs, onset of action of these drugs is much slower than that of the beta 2 agonist. Now, what are the side effects? See, when these drugs are inhaled, in that case, there is minimal side effect, except there is bitter taste with ipratropium, and when it is used in COPD, because of the bitter taste, it may reduce the compliance. Then there can be other anticholinergic side effects like dry mouth, and in elderly, there can be urinary retention. Fine. So that was about anticholinergics. Moving on to the last bronchodilators, that is the methylxanthines. Now, when we were talking about that how bronchodilation occurs, I told you about increased CMP causes bronchodilation or bronchorelaxation. Now, this CMP is broken down by an enzyme phosphodiesterase to 5-AMP. If we block this phosphodiesterase enzyme, that is by methylxanthines, which block this phosphodiesterase enzyme, in that case, this CAMP will not be broken down and there will be accumulation of CAMP, thus causing more bronchodilation. So that is the mechanism of action of methylxanthines. Example of these drugs include theophylline, enprophylline, doxophylline. But remember that now these drugs are not much used in asthma because of their high toxicity profile. So what are the main drugs, main bronchodilators used in asthma? It is beta 2 agonist, and in COPD it is the anticholinergics which are used, right? Moving on to the next class of drugs, that is the leukotriene modifiers. We have seen in our treatment strategies there are two types of leukotriene modifiers. One, which inhibit the synthesis of leukotriene. Second, leukotriene receptor antagonist. Okay. So more common amongst these which are used are leukotriene receptor antagonists. So these drugs are given orally, and examples of these drugs include montelukast and zafirlukast. Montelukast is shorter acting, its T half is 3 to 6 hours, while zafirlukast is longer acting, its T half is 8 to 12 hours. But even though these drugs are used in some conditions that we will talk about, but some patients do not respond to these drugs and they are known as non-responders. That is because we have seen that it is not only leukotrienes which are responsible for the airway inflammation in bronchial asthma. There are many other factors involved. And if in certain patients leukotrienes are not that much important in airway inflammation, so they will be non-responders for this leukotriene receptor antagonist. So we have to try for some time. If it doesn't work, then we have to switch to other drugs. Side effects include concern with suicidal tendencies, and also there have been severe cases of Churg-Strauss syndrome, which is a kind of vasculitis. It is a rare disease, but there have been cases with the use of these drugs. So what are the indications for use of these leukotriene receptor antagonists? Well, they can be used in mild to moderate asthma instead of inhaled corticosteroids. So I told you before that if episodic asthma has become more common, that means beta-2 agonist is used more than 2 times per week, then we have to add inhaled corticosteroids. But in children, there is risk of growth retardation with these inhaled corticosteroids. So in them, we prefer this leukotriene receptor antagonist, right? Then they can also be added in case of prophylaxis for severe asthma. So apart from long-acting beta-2 agonist with the inhaled corticosteroid, these drugs can also be added. But they are the preferred drug for two types of asthma. One, aspirin-induced asthma, and second, exercise-induced asthma. So in aspirin-induced asthma, what happens? See, aspirin blocks COX enzyme. Right, so again in NSAIDs we have seen that arachidonic acid actually is converted by COX enzyme to prostaglandins and all. But there is another enzyme, that is lipooxygenase enzyme, will lead to formation of leukotrienes. Now when we block this COX enzyme, arachidonic acid is diverted to another pathway, that is by the action of the lipooxygenase enzyme, more leukotrienes will be formed. So, aspirin can lead to asthma in some patients, and in these patients we avoid using NSAIDs, and if they are must to use, then we have certain treatment strategies, that is aspirin desensitization and all. We are not bothered about that in this video. But in aspirin induced asthma, we can use leukotriene receptor antagonist because arachidonic acid has been diverted to leukotriene formation. So, these are the best drug to use in aspirin induced asthma. Then exercise-induced asthma, again leukotriene receptor antagonists are used. Then next indication for these drugs is perennial allergic rhinitis. So allergic rhinitis which stays throughout the year, that is known as perennial allergic rhinitis, and for these drugs this leukotriene receptor antagonists are used. Then we have the second drugs in this leukotriene modifiers, that is the synthesis inhibitors. So these are going to block the lipooxygenase enzyme. We have drug Xelutin, which has a short duration of action. Again, not very commonly used because it has some hepatotoxic potential, right? Moving on to the next class of drug, that is the mast cell stabilizers. In mast cell stabilizers, we have sodium chromoglycate, also known as cromolyn sodium, which can be given only by inhalation route. Then we have ketotifen. Now, these drugs can be used in children and exercise-induced asthma, but they are not much used now because of the availability of better drugs, right? Then we have very important corticosteroids. So corticosteroids are the anti-inflammatory drugs, and remember that if the patient is using beta-2 agonist more than 2 times in a week, then it is must to add corticosteroids in the treatment regime. So as told, they decrease the inflammation, and there are various mechanisms by which they decrease the inflammation that in detail we are not going to see. But fundamental physiology that they decrease eosinophil recruitment, and this conversion of phospholipid to arachidonic acid is by an enzyme phospholipase A2. And the mediators which we have seen, that the leukotrienes, they are synthesized by the action of 5-lipoxygenase on this arachidonic acid. So if we block this enzyme phospholipase A2, then arachidonic acid will not form, and hence the mediators are also not going to form. So corticosteroids block this enzyme as well, and they retard the disease progression. Now, corticosteroids can be given as inhaled form, which is the most common form which is being used, and they can be given as systemic also, that is as oral corticosteroids, or IV also in case there is severe exacerbation of asthma. So first, very important is inhaled corticosteroid. Now in inhaled corticosteroids, we have beclomethasone dipropionate, fluticasone dipropionate, budesonide, cyclesonide, and amongst these, fluticasone is used when there is a requirement of higher doses, because this drug has high potency and longer duration in action. So it is preferred in patients requiring higher doses. Another thing is that these inhaled corticosteroids, see, because they are being inhaled, they are directly going to the site of action, and they are being minimally absorbed into the circulation. So systemic side effects are minimal. However, when the dose increases more than 600 micrograms per day, then we start getting systemic side effects. Okay, so that we have to remember that okay, when lesser dose, then systemic side effects are minimal, but when dose increases, then systemic side effects start. So in that case, again, fluticasone is preferred because yes, it is higher potency, so lower dose can be used, right? Another is cyclesonide. Cyclesonide is actually a prodrug and is converted to active metabolite by an enzyme esterase within the airways. Okay. So only when it is converted to the active metabolite, then only it is able to act. Now, if it is going into systemic circulation, then there it will not be converted into active metabolite. So with cyclesonide also, systemic side effects are minimal. So what are the indications for using this inhaled corticosteroids? One, obviously, as I told, that persistent asthma is there if beta-2 agonist requirement is more than twice per week. Then sometimes when the patient is given oral corticosteroids, so suppose there is asthma which is not responding to inhaled corticosteroids and you have started oral corticosteroids, then after some time we will try to withdraw this oral corticosteroid and then we have to shift to inhaled corticosteroids. But remember that this inhaled corticosteroid has no role in status asthmaticus. That means in the severe exacerbation of asthma, acute condition, that time this corticosteroids won't work. Another indication for inhaled corticosteroid is seasonal rhinitis, perennial allergic rhinitis, vasomotor rhinitis. So in that case, these inhaled corticosteroids can be used as intranasal puff. Fine. Now, what are the side effects? Side effects are basically local. That means because of the deposition of the drug in the local area. So there can be hoarseness of voice, there can be sore throat, there can be oropharyngeal candidiasis. And these can be prevented by doing gargle after every inhaled dose. Okay, so that we have to counsel the patient that after taking the dose, they have to do gargle, right? Then moving on to systemic corticosteroids. So what are the indications for systemic steroids? One, severe chronic asthma not responding to beta-2 agonist and inhaled corticosteroids. So in that case, we need to add oral corticosteroids. Then next is status asthmaticus, that is the acute severe exacerbation of asthma. In that case, IV glucocorticoids are given, and then as the patient responds, we have to shift to oral corticosteroids, and also they are given in COPD during exacerbation. Now we are saying that oral corticosteroids, when you start, you have to try to shift to inhaled corticosteroids as you get the response. Why is that? Because we are not giving systemic steroids for long duration because there are high risk of side effects which include peptic ulcer, osteoporosis, like any other steroids. Okay, peptic ulcer, osteoporosis, cataract, capillary bruisability. Okay, So these are the various side effects which can occur with the steroids. Then glaucoma also. Then growth retardation. Remember that steroids, even inhaled steroids, are not preferred in children because of the risk of growth retardation, right? So in children, which one will be preferred? It will be leukotriene receptor antagonist. Okay. Moving on to the newer drugs. So we have some newer drugs, that is anti-IgE antibody, which is omalizumab. And this can be used in severe asthma which is not controlled with even high dose of inhaled corticosteroid. So this immunoglobulin E monoclonal antibody can be given by subcutaneous injection every 2 to 4 weeks. And then we have interleukin 5 antibody, that is mepolizumab. Then we have interleukin 4 receptor antibody. Actually, this receptor is common for interleukin 4 as well as interleukin 5 receptor has this subunit. Okay, so there is that antibody as well. So these are the various newer drugs, right? Now, moving on to the treatment protocol of asthma. So first drug which is used is short-acting beta-2 agonist, and this is used in mild episodic asthma. If the bronchoconstriction is happening rarely, say suppose once a week or sometimes it is happening and there is no frequent need of using the drug. So we use only short-acting beta-2 agonist as needed. Whenever the patient needs, he uses this inhaler. Then we have mild persistent asthma with occasional exacerbation. So in this case, we have to step up the therapy. So that is step 2. Now, if this beta-2 agonist is needed for more than 2 times weekly, then we add low dose inhaled corticosteroids or leukotriene receptor antagonist also we can give regularly. So that is for regular treatment, but as needed we can add short-acting beta-2 agonist. Then if the patient is not responding to that as well, then again we step up the therapy. Now, for as needed also, we have to shift to low dose inhaled corticosteroid with long acting beta-2 agonist. So now we are not using SABA. We have moved to as needed basis also. We have moved to low dose inhaled corticosteroid plus long acting beta-2 agonist. And for regular therapy, now we add long acting beta-2 agonist. See, in step 2 it was only low dose inhaled corticosteroid. Now we have added low dose inhaled corticosteroid with long acting beta-2 agonist, or we can increase the dose of inhaled corticosteroid only. But always it is preferred that inhaled corticosteroid are used in dose as less as possible because of the risk of side effects, right? So this option is better, that is adding LABA to low dose inhaled corticosteroid. Then moving on to step 4, you see from step 4 onwards as needed it is same, that is low dose inhaled corticosteroid plus LABA, but regular treatment we are increasing. So for step 4, if the patient is not responding with the low dose inhaled corticosteroid and LABA, we increase the dose of inhaled corticosteroid, we make it medium dose plus long acting beta-2 agonist. In step 5, we increase the dose of inhaled corticosteroid further to high dose. With LABA, we also add the long-acting muscarinic anticholinergic, that is the tiotropium bromide, right? Then we have the step 6. So the patient has not responded to this as well, and in this case we have to add oral corticosteroids. And as I told before, that whenever the oral corticosteroids are added, we try to withdraw these oral corticosteroid and shift the patient back to inhaled corticosteroid periodically, right? So that is oral corticosteroid. Now the patient may not respond even to oral corticosteroids and there may be need for frequent hospitalizations. In that case we use anti-IgE antibody and IL-5 antagonist. So this is the step up approach for the treatment of asthma. Now this is the regular treatment of asthma and as needed, but if the exacerbation of asthma is too much, the patient is becoming hypoxic, they are having difficulty in breathing, that is known as status asthmaticus and the patient needs to be hospitalized. So in this case, intravenous glucocorticoids are given, that is hydrocortisone hemisuccinate, nebulized short-acting beta-2 agonist, short-acting muscarinic antagonist are given along with oxygen therapy. Then salbutamol, that is short-acting beta-2 agonist, is given also by intramuscular and subcutaneous injection, because the person may not respond to nebulized if the drug is not going into the small bronchioles. See, there is already bronchoconstriction, there is a mucus plug formation. So it may be that the drug doesn't reach to the site of action. So in that case, the patient is not going to respond. So we have to give intramuscular subcutaneous injections also, so that via blood the drug can reach to the site of action. Then there may be need of intubation and mechanical ventilation, and we also have to provide other supportive treatment like correction of acidosis. Now, finally, we have certain special cases of asthma. So one is seasonal asthma. In seasonal asthma, we start inhaled corticosteroids 3 to 4 weeks before season starts. So the person will tell you that in this particular season he is getting the asthma. So in that case, we advise the patient to start the inhaler 3 to 4 weeks before season starts, continue throughout the season, and continue for 3 to 4 weeks after season is over. That is one. Then we have nocturnal asthma. So for nocturnal asthma, we cannot use short-acting beta-2 agonist. Why? Because they act for only suppose 4 hours. So we have to add inhaled corticosteroid with long-acting beta-2 agonist. See, I told you long-acting beta-2 agonists are never used alone. Always they are used in combination with inhaled corticosteroids. Then there is exercise-induced asthma. Now, if the person is getting exercise-induced asthma, it may be that the person's asthma itself is not responding to the treatment. So, it may be if we add inhaled corticosteroid, then exercise-induced asthma improves. But sometimes, actually, asthma exacerbation is induced by exercise only. So, in that case, the drugs used are again leukotriene receptor antagonist or long-acting beta-2 agonist, again with inhaled corticosteroids. Okay, so exercise-induced asthma preferred is leukotriene receptor antagonist. Then we have aspirin-induced asthma. Aspirin, as I told you, it is COX inhibitor, and when the COX is inhibited, then arachidonic acid is diverted to the formation of leukotrienes. So in that case, we give leukotriene receptor antagonist because we have to block the action of leukotriene. So that becomes the most preferred drug for aspirin-induced asthma. So that was about the drugs for asthma, and as for other pharmacology videos, the video notes of this lecture will be available for free download from the app. Thanks for watching the video. If you liked it, do press the like button, do share the video with others, and don't forget to subscribe to the channel Physiology Open. Thank you.